Okay. Well, thank you everyone and welcome. Thank you for joining us today for our New England Dairy webinar, The Importance of Maternal and Infant Iodine in Babies' Brain Development with Dr. Elizabeth Pearce. I'm Hilary Wallentuck, Registered Dietitian and Senior Nutrition Specialist with New England Dairy, and I'll be your moderator today. Before I begin, just a few housekeeping items. You are muted. However, if you have questions throughout the webinar, please type those in the Q&A box. We will work to answer your questions at the end of the webinar. We have also shared your questions from the registration with Dr. Pearce, who will be answering them throughout and during the Q&A portion. This webinar is being recorded and will be available on New England Dairy's website early next week. Tomorrow, you'll receive an email containing a short evaluation to access your CPE certificate and the webinar slides. And we invite you to stay connected and follow New England Dairy. And please stay tuned for more live webinars throughout the year. But in the meantime, we have 15 free hours of continuing education on our website. You can scan the QR code right there on the screen or visit newenglanddairy.com to register. Now I'm thrilled to announce today's speaker, Dr. Elizabeth Pearce. Dr. Pearce is a professor of medicine and the Endocrine Fellowship Program Director at Boston University School of Medicine in the section of endocrinology, diabetes, and nutrition. She received her undergraduate and medical degrees from Harvard and a master's degree in epidemiology from the Boston University School of Public Health. She completed her residency in internal medicine at Beth Israel Deaconess Medical Center and her fellowship in endocrinology at Boston University. She serves as the regional coordinator for North America for the Iodine Global Network and is a deputy editor at the Journal of Clinical Endocrinology and Metabolism. Dr. Pearce is currently serving on a World Health Organization guideline advisory panel related to assessment of iodine nutrition. Her research interests include the sufficiency of dietary iodine in the U.S., thyroid function in pregnancy, the thyroid effects of environmental disruptors, and the cardiovascular effects of subclinical thyroid dysfunction. Now I will pass it off to you, Dr. Pearce, to get us started.
Thank you. It's a pleasure to be here. I'll ask you maybe, let me just get my slides up 1 second. All right, can you see that?
Yes, you are all
Excellent.
set.
All right, we're good to go. So thanks again for that kind introduction. And I want to discuss iodine nutrition, which is, I think, something that's maybe not discussed as often as perhaps it should be. By way of disclosure, I have received honoraria for speaking from the National Dairy Council in this last couple of years. And I'm a member of the Management Council of the Iodine Global Network, which is the NGO for iodine nutrition. So just to set the stage before we really jump into iodine, as a reminder, the first 1,000 days of life are defined as the period from conception until a child is 2 years old. And that's a period of tremendous brain plasticity. So during that period of rapid brain development, we have sort of development of the neurons of the central nervous system, and then they kind of migrate into the right place. They become myelinated, they form synapses. And this is happening at a very, very rapid pace during gestation and during the first couple of years of infancy. It does, of course, not stop until the teen years. Anybody who's ever been a parent of a teenager knows that this is a long process. But we focus a lot on the importance of kind of the environment to really optimize brain development in these first couple of years of life, and especially in pregnant women. The Dietary Guidelines for America first mentioned iodine really in 2020 and focused in the most recent iteration on the importance of nutrition in this first 1,000 days of life period, noting that for toddlers and infants, it can be a little bit challenging to get all the nutrients in because small people eat small amounts, and it's important to make every bite count in terms of nutritional content. And I'll be focusing mostly on pregnant women today. And the report card from the Dietary Guidelines for Americans for nutrition in pregnant and lactating women in the US is kind of dismal. Adult women in general sort of get maybe a C, a 54 out of 100 in terms of quality of diet. And that does go up a bit in pregnancy and lactation. These are times when women often are really making an extra effort to eat really healthfully. But if you look at current national metrics, suggests that women who are pregnant and lactating remain pretty low in vegetable and fruit intake and also in dairy. Now, I'm going to focus really exclusively on iodine today, but would note that there are other nutrients that are also very important for this brain development process, maybe in particular iron and choline and long-chain polyunsaturated fatty acids. So with all that as background, jump into the role of iodine. And we absorb iodine fairly readily through the gut. So when we get it in the diet, it's absorbed by the GI tract and it circulates in the bloodstream. And it can basically meet one of two fates. So either it's taken up by the thyroid gland and used to make thyroid hormone, or it just winds up getting excreted by the kidney. And if it is used to make thyroid hormone, ultimately those thyroid hormones will be metabolized, the iodine gets pulled off, gets back into circulation, and again, can either be taken up by the thyroid and reused or renally excreted. So ultimately, about 90% of the iodine we ingest is going to wind up in our urine. And the only known use of iodine in the human body actually is in the production of thyroid hormone, but that turns out to be quite an important function because the thyroid hormones regulate metabolism, and particularly in early life, they're extremely critical for brain development. Women who are pregnant need more iodine in the diet than the rest of us, and that's partially because the normal hormonal changes that start in early gestation typically will drive an increase of about 50% in thyroid hormone production. So in order to make all that extra hormone, they need extra iodine as substrate. In addition, the fetus has a thyroid by about week 10 or 12 of gestation, and that fetal thyroid is starting to work by somewhere around week 16 to 20. So in the second half of pregnancy, when the fetus is now starting to make its own thyroid hormone, it needs iodine, which can cross the placenta from the mother. And as if that weren't enough, in addition to needing the extra iodine to sustain both the maternal and the fetal thyroid hormone production, iodine is probably just passively cleared at the kidney. This isn't very well regulated. So when glomerular filtration rates rise, as they typically do starting late in the first trimester, more blood flow through the kidney just causes increased renal iodine losses. So probably women who are pregnant are excreting about 30 to 50% more iodine in the urine than they would outside the pregnancy setting. And for a woman who breastfeeds, the iodine requirements continue to be quite high because lactating breast tissue expresses a sodium iodide symphorer, which is a transporter that normally is used to move iodine from the bloodstream into the thyroid gland. But in lactation, its purpose seems to be to really concentrate iodine in breast milk because that's going to be the only source of iodine nutrition for a breastfed infant. So the iodine content in breast milk is about 20 to 50 times higher than it is found in circulation in the plasma. So how much iodine is needed to sustain normal thyroid hormone production depends on your life stage. In children, that's going to be less than in adults. And in infants, we actually don't have an RDA. It's not felt that the data are sufficient to really form firm conclusions. So instead, we have an adequate intake, which is a more conservative measure. So it's not here that the infants need more iodine ingestion than older children. It's just that we're not quite sure what the thresholds should be. But note here that for adolescents and adults who are not pregnant or lactating, need about 150 micrograms of iodine daily to sustain thyroid hormone synthesis, but that's higher in pregnancy, somewhere around 220 micrograms a day, and then higher still in women who are breastfeeding who need about 290 micrograms of iodine. At the population level, we can assess iodine status usually using urinary iodine concentrations. And the World Health Organization has provided some metrics for defining population iodine status based on median urinary iodine concentrations. So in groups of adults and school-aged children, optimal iodine nutrition is really signaled by having a median urinary iodine concentration somewhere in the range of about 100 to 200 micrograms per liter. Anything less than 20 micrograms per liter for the population median signals really extreme severe iodine deficiency. And anything over 300 micrograms per liter is probably a population that's getting iodine excess. Now, these metrics shift in pregnancy. where women need more iodine to sustain thyroid hormone production and also are losing more iodine in the urine. So populations of pregnant women, we can assess, again, using median urinary iodine concentrations, and those levels of between about 150 and 250 micrograms per liter would be a signal for really optimal iodine nutrition in that population of pregnant women. In lactation, the WHO has given us a threshold for urinary iodine concentration, but that's probably wrong. Because most of the iodine that's secreted in pregnant women, or sorry, in lactating women, is not in urine, it's in breast milk. And more recent studies have suggested that you'd really need to measure both the breast milk iodine content and the urine iodine content to really understand this. And that's effectively not really practical for large population surveys. So for right now, we don't really have a good metric for lactating women. The WHO is currently revisiting some of these metrics and maybe issuing some new guidance in the next year or so. Now, very importantly, all those metrics for urinary iodine concentration apply to populations. They do not apply to individual patients. And that's because for all of us, urinary iodine concentrations are up and down on hour to hour, day to day. They really reflect what we've ingested in the last few hours. And most of us are not ingesting sort of consistent amounts of iodine hour to hour and day to day. So because of this really dramatic amount of intra-individual variation, it's been estimated that you'd ideally need 10 or 12 separate spot or ideally 24-hour urine measurements to assess chronic iodine intakes with even 20% precision. I personally have never met a patient who would be willing to do 12 24-hour urine collections, but even 12 spot collections is not practical. And effectively, we really do not have an individual biomarker for iodine status. So therefore, clues about iodine nutrition can come from history and can come from knowing the population status in the local area, but we don't have a lab test we can use to definitively diagnose a patient in our office as having, deficient or sufficient iodine intake. So with all that as background, I'd like to convince you now that this actually matters. And when there is not enough iodine in the diet, there are consequences across the life stage, but those consequences are going to really vary depending on who you are. So at any age, when there's really inadequate iodine in the diet, there will not be an ability to synthesize adequate amounts of thyroid hormone, and people will develop hypothyroidism. Goiter is thyroid enlargement, and a thyroid that is consistently not getting enough iodine and is kind of struggling to produce thyroid hormone tends to enlarge over time and may become really large and bulky and cause discomfort, can be disfiguring, can cause difficulties swallowing or breathing. So goiter is one of the most visible consequences of iodine deficiency. But the spectrum of iodine deficiency disorders is much broader than that. It's not just the thyroid enlargement that's visible or the hypothyroidism that we can measure. We know severe iodine deficiency has quite severe obstetric consequences. So higher risks for miscarriage, for stillbirth, for maternal and infant deaths around the time of delivery. Children in profoundly iodine deficient areas can be born with a syndrome known as cretinism, which I'll show you in a moment. But from a public health perspective, the major impetus for fixing this problem and trying to prevent iodine deficiency disorders is the sort of radical impact that iodine has on the developing brain. And so when there's inadequate iodine nutrition, particularly in early life, we can see impaired mental development. This is cretinism. It's kind of a classic photo taken in Zaire, and the individuals standing in front are young women who are adults, same as the young man standing behind them, but they all, unfortunately, would have been born to mothers with really profoundly low iodine intakes. So probably less than 20 to 25 micrograms a day, which is less than a tenth of what we think is truly required. And as you can see from the photo, that results in really profound impairment of growth. You can see some abnormal facial features. Often these children are born with deafness because thyroid hormone and therefore iodine is important for development of normal hearing. And really tragically, these individuals tend to have very impaired intellectual development. Thankfully, in 2024, this is an incredibly tragic outcome, but it's become very, very rare around the planet. What we're much more worried about are more subtle degrees of cognitive impairment related to inadequate iodine nutrition. And really, the impact of iodine deficiency on the developing brain is going to depend both on the severity of the iodine deficiency, also probably on the timing during gestation or in early life of that exposure. We know, again, that iodine deficiency during gestation in pregnant women can lead to decreased hearing in children. It can lead to lower IQ, and often it's especially verbal IQ that seems to be impaired. And we think there's something about thyroid hormone and therefore about iodine nutrition that's particularly critical for the language centers in the developing brain. And then finally, over the last decade, we've seen some increasing evidence that it's not just IQ that seems to be altered in the developing brain when there's not enough iodine around, but there may be also neurobehavioral consequences. So higher risk for disorders like attention deficit hyperactivity disorder, or potentially for autism spectrum disorder. Now, we've known for decades now, really since initial trials were done in the late 1960s, that if we can optimize iodine nutrition in severely iodine deficient regions, we will improve population IQ quite substantially. And meta-analyses in the last few years have suggested that that increase is somewhere between about 9 and 12 points. And a population level average increase in IQ of that magnitude has really profound implications, not just for individual health outcomes, but really for whole societies and for whole economies, because IQ really drives economies. Now, we've known that for decades. What we've actually really only understood since about 2013, in the last decade, is that this is a spectrum, and that even fairly mild levels of iodine deficiency seem to be linked to measurably lower child IQ. And the landmark study that really first brought this issue to our attention was one by Sarah Bath and colleagues. It was done in the United Kingdom. And they looked at a cohort of pregnant women from the UK, which is, and sadly still is, reasonably iodine deficient, or at least mildly to moderately iodine deficient. And they looked at maternal urinary iodine concentrations in the first trimester of pregnancy, and then linked them to child development assessed at 9 years of age based on IQ scores and reading test scores. And what they saw was really a dose-response relationship. So the lower the maternal iodine exposures in early gestation, the lower the children's verbal IQ and also reading accuracy and comprehension scores. And what was particularly concerning and what was particularly novel about the study was the finding that we could start seeing measurably lower child IQ when there was only a modest decrease in urinary iodine concentrations, signaling probably really fairly mild iodine deficiency. So it may not just be those regions that are profoundly iodine deficient where children are born sporadically with cretinism, but regions that are only fairly marginally iodine deficient where we can see effects on development. And we think in 2024 still that iodine deficiency remains the most preventable cause of intellectual disability around the planet. Now, important to note that for iodine, as is true really for most other nutrients, more is not always going to be better. And that there's probably a U-shaped relationship between iodine exposures and risk for adverse outcomes. This is a study from Norway where they looked at maternal iodine intakes as assessed by food frequency questionnaire in the second trimester of pregnancy, and then linked that to the likelihood that children would have language delays at 3 years of age. And this is a massive study. The sample size is about 33,000 mother-child pairs. And in that very large sample, what they could see is this U-shaped relationship, that women who had probably iodine intakes that were too low in pregnancy, but also women with iodine intakes that were too high in pregnancy at higher risk for having children with these language delays in early life. Similarly, we have a cohort here from China where they looked at urinary iodine concentration in about 7,200 women in very early pregnancy, and just looked at associations with the likelihood that women would have mild hypothyroidism in that early gestational age. This was overall an iodine sufficient cohort based on WHO metrics. But what they saw, again, is another U-shaped relationship. So women with low iodine intakes, but also probably women with excessive iodine exposures being at higher risk for having low thyroid hormone levels in early gestation at that time when we know that's particularly important for the fetal brain development. So in the United States and globally, how are we doing for iodine nutrition and where are we getting it? So I'm going to take you back 100 years. And before the early 1920s, this whole orange area of the country, really with an epicenter around the Great Lakes, but encompassing most of the Pacific Northwest and really much of New England outside the immediate coastal areas, this was known as the goiter belt. Goiter, again, is thyroid enlargement, and you get thyroid enlargement in regions where there's inadequate iodine in the diet. And this really reflects the fact that there's probably limited amount of iodine in the soil in this part of the world. And therefore, if you are eating locally produced foods, which 100 years ago, pretty much everybody was, if there's not iodine in the soil, that's going to translate into low iodine in fruits and vegetables and meat, milk, eggs, all the food that is produced in that part of the world. And so there were rates of goiter, either visible or palpable goiter, up to 70% in some counties within this US goiter belt. So in the 19 teens, this would have been a very visible, very obvious public health problem. People were well aware that this was an issue, but they didn't actually know what caused it. In the 19 teens, at the time of recruitment for soldiers for World War I, a shockingly high proportion of potential military draftees were considered ineligible for service, either because their necks were just so big they couldn't button a military uniform, or sadly, probably because they had intellectual impairment related to iodine deficiency in their mothers, during pregnancy. In the 19 teens, somebody named David Marine, who was a physician in Cleveland, Ohio, kind of dead center of the goiter belt, did clinical trials in schoolgirls that really definitively demonstrated for the first time that the problem that led to this so-called endemic goiter was really inadequate iodine, and that goiter could be treated or prevented by giving people adequate iodine. So based on that study, there was a pretty rapid response from the US public health community. And starting in Michigan in 1924, and then just within a few months, rolling out to national distribution, in the US, we started iodizing salt in 1924 as a way of preventing iodine deficiency disorders. And we were the second country in the world to do this. Switzerland beat us by 2 years, so they started in 1922. Morton Salt was the first company to have national distribution of this iodized salt, and this is one of their advertisements from the 1920s that says American mothers are bearing better babies since the introduction of the salt, and that was probably true. Economists about 10 years ago went back and looked at standardized test scores from across the United States from before to after this period of salt iodization starting in the early 1920s. This predates, of course, things like the SAT tests, but they had standardized exams that were administered to military recruits. So based on those test scores, they estimate that for the quarter of the US population that was most iodine deficient, salt iodization raised IQ by an average 15 points. Again, kind of mirroring what we've seen more recently in meta-analyses looking at the effects of iodine fortification programs in other parts of the world. So again, this profound change in public health that was 100 years ago. And we've honestly, I think a lot of people have just forgotten this. People don't know why there's iodine in salt anymore. So salt was picked as the vehicle for iodine fortification for a number of historical reasons, but it turned out to be a pretty effective vehicle in most parts of the world. And globally, this is still the primary intervention that public health organizations are using. People around the globe tend to eat fairly similar amounts of sodium, day to day. It's used pretty much in all households around the planet, and it's very inexpensive to add iodine to salt. As we have become more aware over the last few decades of the downsides of excess sodium ingestion in terms of cardiovascular disease, it's sort of become incumbent on public health organizations and government public health bodies to harmonize plans for reducing sodium intakes with salt iodization program. And this can be done. If sodium iodine intakes are monitored in the population, one can ramp up the amount of iodine in salt to sort of keep pace, but this does require sort of careful coordination and careful monitoring at the population level. Now, in 1993, the World Health Assembly passed a resolution that as a public health community, we were going to eliminate iodine deficiency using salt iodization. Now, in 1993, this was going to be a rather challenging thing to do because all of these countries in purple were iodine deficient. It was really most of the planet outside North America. So 110 countries considered to be iodine deficient in 1993. The US and Switzerland at this point had been using iodized salt for decades. Canada had been as well at that point, but most of the rest of the world really hadn't adopted it yet. So starting with this massive push in 1993, a lot of governments around the world sort of set up iodized salt programs. And 10 years later, we had reduced the number of countries considered to be iodine deficient by half, so down to 54. And progress really has continued. So here we are in 2007. 2012, we start to see some countries in red on this map rather than purple. And these are countries where there's been inadequate monitoring of the amount of iodine in salt, and populations have swung from being iodine deficient to actually getting iodine excess. Most obvious one on this map is Brazil. That's been fixed, but Colombia and in South America still has issues with iodine excess currently. So this is the most recent map for iodine nutrition, and this is put together by the Iodine Global Network and the World Health Organization on an annual basis. And you can see that most of the world now is white, meaning we think sort of getting optimal iodine status at the country level. There, we are down to 21 countries that are considered to have iodine deficiency and 14 considered to have iodine excess. So this represents really a massive public health achievement. And when we modeled this based on declining rates of goiter and on urinary iodine concentrations from countries around the world, we estimated that between 1993, when there was this huge global push to start iodizing salt, and 2019, when we did this assessment, we probably averted about 720 million cases of kind of clinically apparent iodine deficiency, which translates into more than 20 million newborns protected from from intellectual impairment annually, and a global economic benefit really related to improved cognition of about $33 billion. So massive accomplishment, but the work is not done. In the United States, again, we iodized salt in the 1920s. By the 1940s, the goiter belt was a thing of the past. All the clinics that were set up to do massive numbers of thyroid surgery started going out of business. Goiter was no longer visible in the population. Nobody really worried about this then until the early 1970s. And at the time of the first NHANES survey, the median urinary iodine concentration in kind of a representative sample of the US population was 320 micrograms per liter. Remember, anything more than 300 is too high. So we were potentially getting excessive iodine in this country. So nobody worried about this for another couple of decades. And at the time of the third NHANES survey in the early 1990s, what we saw, to everyone's consternation, was that iodine intakes in the United States had dropped by half. They had remained in the optimal range. This is not deficient. Again, in the general population outside pregnancy, we want this number to be somewhere between 100 and 200. But there was great concern that this decline might continue. And so the CDC is now assessing urinary iodine concentrations on a rolling basis in the NHANES surveys. What we're seeing most recently, perhaps, is a continued decline, although the US is remaining so far overall in the optimal range. Now, I think the big decline in iodine nutrition has been multifactorial. One of the factors probably is that in the 1940s, commercial bread bakers in the United States started adding iodate dough conditioners to their products. This was not done as a public health initiative. This was done because these dough conditioners were supposed to cause sort of better bread textures and improve shelf life. But in the 1960s and 70s, there started to be concerns about excess iodine in the US population, and commercial bakers started sort of taking this out of their products. So one reason for big declines in iodine nutrition may have been a shift in what our bread bakers are doing. It's still available in some breads that have high iodine content, but not in the majority. There's been a growing, I think, understanding that we don't want sodium excess in people's diets. So people have phased out some of their salt intake over the last several decades, but also people have forgotten why there's iodine in salt. And we've seen big increases in use of non-iodized salts. Importantly, the fancy pink Himalayan sea salt that every cooking magazine wants you to use. Most sea salts, most kosher salts are actually not iodized salt. In addition, dairy has probably become the most important source of iodine in the US diet because of the decreases in some of these other sources. but only 2% of the US population is meeting current recommendations for dairy intake. And there are a whole lot of people who don't ingest dairy at all and probably missing out on a major source of dietary iodine. Seafood tends to be high in iodine, but Americans don't actually eat a whole lot of seafood, so we don't think that's playing a huge role. Now, the maps I showed you as we're sort of getting more white or more gray, seeing more and more countries that are sort of considered to be iodine sufficient, those are all based on studies done of urinary iodine concentrations in school-aged children. And it turns out that if you measure urinary iodine concentrations in the same place at the same time in pregnant women and school-aged children, you get different results. That half of the time when the school-aged children have urinary iodine concentrations signaling really optimal iodine nutrition, the pregnant women are low. And that's probably partially because the pregnant women just have higher iodine requirements and partially because diets are different. But if you look at the global status of iodine nutrition in pregnant women around the world, things really are not quite as rosy as the maps I showed you a few minutes ago. So note a lot more purple on these maps, including a lot of countries like the United States, like much of Western Europe, like Australia and New Zealand, where these are not populations we usually think about as having nutritional deficiencies. This is not a question of resource scarcity. It's really a question of political will. South and Central America continue to be largely iodine sufficient. Much of Africa is white here because we have no data. So there's some inequities in who's getting studied and tested. But what we see is there's still work to do to address iodine deficiency in pregnant women. This is the group most vulnerable to the effects of iodine deficiency disorders, but also a hard group sometimes to target and to study. In the United States specifically, the trends in iodine nutrition in pregnancy have mirrored the trends in the general population. At the time of the first NHANES survey in the early 1970s, again, there was probably excessive iodine intake in pregnancy, but we saw a big decline as we did for the rest of the population. And specifically in the last 15 years or so, 15 to 20 years, we've seen urinary iodine concentrations in the United States dropping below WHO thresholds for sufficiency. So really a reemergence of mild iodine deficiency, specifically in pregnant women in the United States. We have no data for women who are lactating. That simply hasn't been measured. So what are recommendations to address this and to try and reduce risk for population iodine deficiency? So one way to approach this is with supplementation. And the American Thyroid Association, the Endocrine Society, the American Academy of Pediatrics have all recommended that in the United States, because we are concerned that there is probably a large proportion of the population of women of reproductive age and pregnant women who may not be getting adequate iodine intake, that women who are planning pregnancy or women during pregnancy or lactation should take a daily supplement that contains 150 micrograms of iodine. Now, that's not the full RDA for pregnancy and lactation. It's designed to sort of complement what's in the diet and try to get the population of pregnant women to kind of the right range. This, though, has not been so easy to implement. So we first made those recommendations back in 2006. And as of the time of the 2011 to 2014 NHANES survey, only fewer than 20% of women who were pregnant or lactating in the United States reported actually taking an iodine-containing daily supplement. And that's despite the fact that the majority of women in this country who are pregnant or breastfeeding do take some kind of prenatal supplement. The problem is not all of those prenatals that are marketed in this country actually contain any iodine. And we've studied this a few times over the years, but most recently, it looks like about 60% of the different types of prenatal vitamins, or the ones with the largest market share in this country, contain iodine, but that means about 40% contain none. And for reasons that I don't really understand very well, the ones that are marketed as over-the-counter products are more likely to contain iodine. The ones that are marketed by prescription only are actually much less likely to contain iodine. And with those, of course, you can't necessarily look at the bottle and know exactly what you're getting. So recommendations are that women who are planning pregnancy, pregnant, lactating, should take that daily multivitamin and should make sure that it's one that actually has 150 micrograms of iodine that's needed. Women don't know to look for this. Health providers don't know to make recommendations about this. Again, I think there's a huge data gap. We did a survey of midwives and obstetricians a few years ago in the United States, and three out of four who responded to the survey really were not making any recommendations about iodine nutrition, or if they were making recommendations, were not recommending adequate amounts. And this concern about the reemergence of mild iodine deficiency in this country is increasing over time. This is something that was first listed in the dietary guidelines for Americans in 2020, that iodine is now considered a food component of public health concern for pregnant women, one where we should consider supplementation because we're not sure that all women are getting this in the diet. You can't do a urinary iodine test or a blood test or any really kind of biomarker to assess iodine status in pregnancy, but history taking can help. Important to note that salt intake doesn't indicate iodine status, because I've told you we have had an increasing number of types of salt that are not iodized sold in this country. Only about 54% of salt sold for household use at this point is actually iodized. And most of the salt that we ingest in the United States is not coming from table salt that's being added, at the table or in cooking at home. It's coming in commercially processed foods, and commercial food processors in the United States, we think, are not using iodized salt. So it's only the 10 or 11% of salt that's really added at home that could be iodized. Only 50% of the salt that's marketed to households is iodized. And women of reproductive age, which is the group we're really trying to reach the most, is the group that's least likely to add salt to foods. So we don't ever want to really recommend that people who are not using salt add more salt to their diets. But if they're using salt, they should make sure it's iodized salt. It's an easy thing to do. We know that dairy probably, as I said, has become the most critical source of iodine nutrition in the United States. And we know from the NHANES survey, for example, that the pregnant women who have the highest dairy consumption really do not seem to be at risk for iodine deficiency. So 3 servings a day of dairy really will optimize iodine nutrition, and also helps women meet other nutritional needs, including increased calcium, vitamin D, choline, potassium, and vitamin B12. Anybody who's not ingesting dairy probably is at risk in this country. If you don't have dairy or iodized salts, you're probably at risk for iodine deficiency, and you can ascertain that with a dietary history. In particular, people who follow restricted diets may have low iodine intakes. We've looked in a small sample of Boston area individuals several years ago, measured urinary iodine concentration in people who said they were following vegan diets and people who said they were following vegetarian diets. And the vegetarians had median urinary iodine concentration for the group that sort of fell within, sort of the average for the United States and was in the optimal range. But the vegans were low, and that's been observed in studies now in a number of other parts of the world, including several countries in Europe. So anybody following a vegan diet who might become pregnant probably is somebody who really, really needs to get an iodine-containing supplement. It's hard to figure out where iodine is in foods because it's not on package label. Outside of very selected sources. So it will be labeled on salt boxes, it will be labeled on infant formula, but it's not labeled on much of anything else. And so consumers can be challenged to try and figure out where the iodine is in their diets. And actually, even people who are experts in iodine nutrition can be somewhat challenged in figuring out where it is. The Office of Dietary Supplements at NIH has taken a strong interest in this issue over the last 10 years or so, and they have put out some really useful information on the NIH website. So if you look up the Office of Dietary Supplements, ODS at NIH, there is a fact sheet for patients, and there's also a fact sheet for providers. And among other things, it lists iodine content of a lot of commonly consumed foods. So for example, a serving of cod gives you about 105% of your daily requirements. 1 glass of milk gives you about 60%. Eggs have less, but are also a reasonable source. And actually in the egg, it's all in the yolk, it's not in the white. So an egg white omelet won't help you so much with the iodine nutrition. But I think this is a helpful resource for people to look up these sources that aren't going to be found on labels. So in conclusion, I would note that we think pregnant women and their fetuses are particularly vulnerable to iodine deficiency disorders, and probably also particularly vulnerable to iodine excess, although that has not to date been a huge issue in the United States. That we have seen a massive public health triumph, I think, over the last 3 decades around the globe. We've massively decreased the amount of iodine deficiency around the planet, mostly due to salt iodization programs. But iodized salt is not reaching everybody it needs to, and particularly in the United States, its use has probably been declining. And we have therefore seen, a reemergence or a persistent of mild to moderate iodine deficiency in the US and in many other regions. And what's particularly concerning is that over the same time period where we're seeing this reemergence of mild iodine deficiency, we also have increasing evidence suggesting that even mild iodine deficiency in vulnerable time periods, particularly during gestation, may have long-term consequences for brain development that are measurable even when the iodine deficiency is fairly modest. So guidance for patients, we want to encourage particularly women who are preconception, pregnant, and lactating to make sure they're getting adequate iodine nutrition. Some ways to do that are by using iodized salt if they're going to add salt, by ingesting foods such as dairy, seafood, and eggs, and then some prenatal supplements, but again, with the important caveat that not all of those prenatal supplements do actually contain iodine, and it's important to look at labels and make sure it's actually there. So I will close with this quote from James Grant, who's a former executive director of UNICEF, that adequate iodine nutrition should be a right of every child and something we're really working on to promote. So with that, I'll thank you for your attention. I think we've left about 15 minutes for questions.
Perfect. Thank you so much, Dr. Pearce. It was a great, very informative webinar. We have a few questions coming in through the Q&A. Just a reminder for folks that just use the Q&A function to type your question. The chat is currently closed. So quite a few questions have come in the Q&A and then in the registration about supplementation, about iodine supplements. Could you talk about them? Is there an ideal iodine supplement? Do you recommend them? Kind of walk us through that.
Yeah, so interestingly, most general adult multivitamins and most multivitamins marketed for children in the United States contain iodine, and most of those contain the RDA for that age group. So for adults, it would be 150 micrograms a day. But it's specifically for pregnant women, the prenatal multivitamins, where the iodine is often not there. So important to look for a prenatal vitamin for the groups who need one that has iodine in it. And again, the amount that's recommended is 150 micrograms a day, which is what most of them contain if they contain iodine at all. But not all sources of iodine in supplements are equal. And if you look at, for example, iodine content of seaweed, which can be very high, not a typical part of the diet for most people in the United States, although it is in some parts of the world. But because there's a fairly variable amount of iodine in seaweed, it turns out that if your supplement is one of those that's sort of marketed as all natural, where they sort of make a point of pride that the iodine is coming from seaweed, the levels of iodine are quite variable too, and they're probably not as reliable. So probably best to look for one where the source of iodine is from potassium iodide, which is what most of them are. It's very difficult to find a supplement on the US market that's only iodine. Almost always the iodine is found in multivitamins. And often the ones that only have iodine are iodine in really huge supraphysiologic doses. And again, there's probably a narrow window to get this right, particularly in pregnancy. And there's really no reason ever to dose anybody with an iodine supplement containing more than 500 micrograms a day of iodine. That actually sets people up for higher risk for thyroid dysfunction. But particularly in pregnancy, a lot of those only iodine containing supplements, if you can even find one, have levels of iodine that are too much. So would favor looking for a prenatal or just a regular multivitamin that has that 150 micrograms as specifically potassium iodide.
Great. So when you talked about foods that contain iodine, and I know cod was on the list, but are there recommendations of other fish or fish that tend to be higher in iodine levels that are more appropriate for pregnant people to focus on?
Yeah, so this gets a little tricky for a couple of reasons. One is the iodine content in fish is really variable, and people have studied this, done measurements of iodine content, and it's variable by species and by region and by time of year. So, for example, that Office of Dietary Supplements page will give you kind of average amounts, but there is some variation there. As a general rule, saltwater seafood is going to contain more iodine than freshwater seafood. And women who are pregnant, of course, want to be very careful about limiting seafood that could have heavy metal content. So also need to sort of be thinking about that in terms of thinking about what safe choices are for seaweed intake, specifically in that vulnerable population.
Another question, is there a quick nutrition screener for pregnant patients that, folks on the call today can recommend for their OBGYN department?
Wow, I wish there were. That's a good idea. So thank you for whoever asked the question. Maybe something we can look into creating. But right now, there really isn't. I think, though, it's a pretty quick thing. Do you add salt to your food? Is it iodized salt? A lot of people don't know. Go back and look in your cupboards. And are you ingesting dairy? And if the answer to both of those things is no, and you're planning pregnancy, pregnant or lactating, I would just supplement. Or anybody with a vegan diet who's not getting at least iodized salt, probably would supplement just at any age.
So you mentioned, vegans and vegetarians, folks more at risk for iodine deficiency. Are there other groups in the United States that might be more higher at risk for iodine deficiency?
We don't know geographically. So our best national data come from NHANES, and NHANES will not break things down by regions because of concerns about privacy of participants in those studies. So we don't know if there still are higher levels of iodine deficiency in what used to be known as the goiter belt. I suspect that's not the case because most people don't eat locally anymore. We get our foods from all over. But other groups who are at risk, I think anybody who's not ingesting dairy, I worry about a lot. And that might not be people sort of following a vegan diet. That might be people who sort of feel like they have lactose intolerance or just, preferences. But I think anybody who is not ingesting dairy is definitely a risk. Because again, that's probably become our primary source, even though the iodine is not necessarily in the dairy specifically as a public health intervention.
So for folks with a dairy allergy, what would you recommend?
I'd recommend a daily multivitamin supplement that contains iodine. And again, what I'd recommend to anybody in the population really, which is if you're adding salt, just make sure, the salt in your cupboard is iodized salt. That remains quite a good source for people who are using it. And we actually iodize our salt at a pretty high level in the United States compared to the rest of the world. So you don't need a whole lot of that iodized salt to start getting to your requirements.
So talking about iodine absorption, where is it absorbed in the body? Specifically, someone asked in the GI tract. And I'll add on, is there anything that can help increase absorption?
So sadly, nothing we know of that helps increase absorption, not contaminant foods or anything else that we're aware of. It's probably mostly absorbed in the jejunum. And, groups that have been studied, for example, are people who have had gastric bypass surgery or people who might have short gut syndrome, and kind of variable data for whether that makes a difference. But that would be another group that I might consider, thinking about extra iodine supplementation for, because that's another group. If you don't if you don't have your whole small bowel, you might be at risk for less absorption.
This question came in the registration as well as live. Should we be concerned about the lead content in iodized salt? Some clinicians on the call have gotten questions from patients about that concern.
Not based on just the process of iodization. And, salt that's manufactured in this country, I think, is probably high quality salt and is not going to contain a lot of contaminants. That is not true in all parts of the world, but lead contamination of iodized salt has really not been an issue. There's not lead in the iodine that's added to the salt. So that really should not be a concern.
Right. So what other conditions mimic thyroid conditions, if any?
So hypothyroidism or goiter, thyroid enlargement, are the two thyroid conditions that are really linked to iodine deficiency. Of course, iodine deficiency is not the only cause of those two thyroid conditions. It's the most common cause around the globe because iodine deficiency historically has been so prevalent around the world. But in parts of the world that are overall iodine sufficient, like the United States, most hypothyroidism is not caused by iodine deficiency. It's caused by thyroid autoimmunity. And also important to note that thyroid function, you can't tell if you're getting adequate iodine nutrition based on normal thyroid function because it's a very insensitive marker. That you can get subtle shifts in the ratio of the thyroid hormones you make that might, impact, outcomes, say, for a fetal brain development that are not actually going to show up as hypothyroidism. So measuring thyroid function, if you have a concern that somebody has thyroid function, you can measure thyroid function directly, but it's not necessarily going to tell you about their iodine status. Other conditions that mimic hypothyroidism, they're about 1.5 million, because one of the key symptoms is fatigue, and almost anything can cause fatigue. So very, very nonspecific, but classic symptoms of significant hypothyroidism: fatigue, constipation, feeling cold all the time, absent or irregular periods in women, hair loss, dry skin would be classic, but those are all very nonspecific symptoms and can be caused by a whole host of other things. Thyroid enlargement can be caused by a number of things. Again, around the globe, unequivocally, the leading contender, the major cause is iodine deficiency, but there are other things that can do that, and sort of a good thyroid laboratory workup and thyroid ultrasound may be necessary to sort of diagnose what the underlying problem is.
Thank you. Are there any studies that look at adding iodine to preterm infant diets?
That's a great question. There are some studies suggesting that those preterm infant diets are low in iodine. We've done studies like that actually at Boston Children's Hospital here locally. And it used to be that preemies in the neonatal intensive care unit got a lot of iodine exposure, not in diet, but through their skin, because iodophore cleansers, betadine, things like that were used, to put in IVs and all kinds of procedures. And because little tiny preemies have very large, body surface area to weight ratio, they can absorb quite a lot of iodine across the skin. And there were historically concerns about too much iodine exposure in preemies in the NICU. But that has shifted because of those concerns about excess iodine potentially adversely affecting thyroid function in those very tiny premature infants. There's been a real move away from using iodinated cleansers in the NICU. So there's still some use, but it's not what it used to be. And so now I think there is a real concern about iodine deficiency, because there may not be adequate iodine in premature infant supplement, formula. And there may not be adequate iodine in breast milk. We've measured donor milk, that was in the local area in New England. And a lot of those milk samples were fairly low in iodine. So a real concern for that population group, and one where I don't think we necessarily know the right answers yet.
Thank you. Is there another question? So is there a benefit to supplementing with iodine if there's a family history of hypothyroidism? And a second, answer that one first, and then I will ask you the second part.
Okay, so family history of hypothyroidism is pretty common, because hypothyroidism is pretty common in the general population, probably about 5% of all adults. It's the thyroid hormone is the most prescribed drug in the United States, and it has been for many years. So it's pretty common family history to have. I don't think it does any harm to take in the amount of iodine we're suggesting, that's somewhere around the RDA of 150 outside pregnancy, 250 in pregnancy. But very excessive iodine intakes, more than 1,100 micrograms a day, for example, which is what the Institute of Medicine has said is the tolerable upper limit for iodine intake for adults. Levels that are very high in people with, sort of mild thyroid autoimmunity, family tendency to hypothyroidism, could actually trigger both hypo and hyperthyroidism and are to be avoided. But those very high levels should probably be avoided in all individuals in general.
And does iodine absorption decrease as we age?
Not that we know of. No, it gets absorbed pretty readily across the gut. We don't actually know if it's regulated much, if at all, but it doesn't seem to shift as people get older.
Are there any interactions with iodine with medications or other dietary supplements?
There are not a lot of interactions with medications, but there are some medications that contain very high levels of iodine. So amiodarone, which is an antiarrhythmic that's often given to patients with atrial fibrillation, contains enormous amounts of iodine, and often actually is a trigger for iodine-induced thyroid dysfunction, just because the levels are so very high. And the other place we tend to give it to people in the medical community is iodinated contrast media. So if you have a CT scan with contrast, there's an enormous amount of iodine that's in that intravenous contrast, and it can take several weeks to wash out of the system.
So another question that came in through the registration, does iodine bond to any other minerals in the blood?
No, not really. It travels I mean, it's an anion, so it's going to bind to something. It's going to bind to to form some kind of salt, but no, not particularly. And it's not binding to, for example, proteins the way thyroid hormone itself does.
Great. Well, just, a lot of great questions today. Where would you point, majority of folks on the line today are registered dietitians or healthcare practitioners. Where would you point them for resources to share with their patients and clients?
Probably two places. So one, again, is the Office of Dietary Supplements, which has been recently doing quite a lot of work on trying to create really good patient resources. So in addition to the provider handouts, there are, printable from the web, patient or consumer handouts about where iodine is and why it's important. And then, if you're interested sort of more broadly in kind of global iodine nutrition, want to look up where, say, your patient, has come from another country, what was the iodine status where they came from. The Iodine Global Network, which is at ign.org, has those maps I showed you from the WHO, and we update those on an annual basis.
Thank you. So that is just about all the time we have for questions. Thank you very much for this excellent presentation, for sharing your expertise with us, Dr. Pearce, and thank you to all the attendees for sharing your time. As a reminder to everyone, you'll receive a link to the evaluation that will lead you to your CPE certificate and slides tomorrow, and the webinar recording will be on our website, and you'll be notified of that via another email next week. And this now concludes our webinar. Thank you again, Dr. Pearce, and thank you all for listening.
My pleasure to be here. Take care.
Take care.